TopMedTalk. Hello, welcome back to TopMedTalk. I'm Andy Cumpstey and I'm here again at the EPBOM, that's the Evidence-Based Perioperative Medicine World Congress here in London, in a really hot, warm, sunny London, I should say, unusual for this time of year. And it's been a really busy conference, lots of people from all over the world coming to talk about their areas of expertise, and people coming from outside the Congress to come and see as well. And I'm delighted that we've got three really fascinating guests all working here in London who've come in specially just to speak to TopMedTalk.
Hi, I'm Jasjit Syan. I'm a cardiology registrar and a clinical research fellow doing the second year of my PhD at Imperial College of London. And the focus of my research is on early detection and preventive algorithms in hospital patients.
Hi, I'm Sadia Khan. I'm a cardiology consultant by day, but I'm also the clinical lead for innovation at Westminster Hospital Trust here in sunny London. Most of my day-to-day work is done on the West Middlesex site in Hounslow, and some of what we're going to talk about has been done on that site.
Hello, I'm Meera Joshi. I'm a oncoplastic breast surgeon at Charing Cross with a research interest in wearable sensors and patient monitoring, and performed my PhD prior to Jas at Imperial College London under the supervision of Sadia Khan.
I'm going to go off-piece straight away. It's very unusual that I get to do one of these TopMedTalk recordings with three non-anaesthetists. I want to ask you about that first. What's it been like working in this sort of space, the monitoring space, and how did you get involved in that space from your background?
So I'd argue that actually there's not that much difference between anaesthetists and cardiologists in terms of monitoring. And if you look at what happens and where traditionally monitored areas in hospitals in particular, or even in the community are, it's cardiology and anaesthetics in large part. So for me, and it also speaks to how I got involved with a surgeon as a PhD fellow, because that's a bit unusual too. I got involved in the monitoring space because our hospital was looking at how we keep patients safer at night times in particular. So if we think ITU staffing at night is difficult, I'd suggest you go out onto the general wards and have a look there.
I completely agree. Again, I'm an intensivist by background, and I love coming back to my ICU because all the patients have got all the numbers in front of me and it's all there. But when I go off into the wild west of the wards, it's pretty terrifying at times, isn't it? And I think you're absolutely right. That's where the monitoring question is, we really need answering. So what sort of things have you been looking at to try and fill that void and fill that gap?
So I might pass that over to Meera, because we've been working in this space for more than a decade, to be honest. And it's really great to see colleagues of mine come up to do research in that space.
From my point of view, throughout my career, very early on, from having a family member in hospital deteriorate, made me realise you think of hospitals as a safe place with lots of monitoring, but sometimes we all know that patients fall through the gaps. And with a strong interest in sort of research and technology and innovation, kind of led me to looking at this problem a bit closer. And so we met a whole host of wearable technology companies and looked at enhanced monitoring, because I think there's such a real flux in terms of monitoring equipment that's out there, and with very little research apart from their own industry, what they say is on the tin. But how does that work in a real world setting with people that may not behave themselves, might not be sitting still, may not have a healthy background, have lots of comorbidities and so on. So I think it's seeing how these systems work in a real world setting in the ward, with lots of other associated factors. So that's really where I came about into it. And then also looking to see how can we predict these things earlier? How do we have a better triage system for unwell patients? From surgical patients who have a lot of monitoring, say, in theatre or in the recovery, and then they go to the ward post-operatively, where they suddenly have very little, especially overnight, as Dr. Khan says, and over weekends and so on. So it's looking at perhaps ways that technology could be an adjunct to care and enhanced monitoring. So that's really where I came into looking at things.
I think you've hit the nail straight on the head with some of our biggest fears from an intensivist anaesthetic background. We do monitor our patients incredibly intensively during that intraoperative period, and that monitoring continues into the recovery period, and suddenly it almost seems to stop completely and they just go off a cliff. I mean, there's good evidence out there showing that that's a problem. So what do we do about it?
Exactly. And this is where we're looking to see, are there ways that we can pick things up earlier and support our allied health professionals, nursing teams, quite junior people to perhaps raise an alarm, which can be quite scary. What does the alerts mean? Are they useful? And looking at ways around, because there are a lot of evidence of alert fatigue, perhaps in the ITU setting. How does that work in a real world hospital setting? Maybe do we use these enhanced monitoring systems, particularly overnight? Maybe that can help patients sleep better if we're not having to wake them up and take their observations, if we know that they're stable. So there are lots of different ways that we can start looking at it, I think. And that's really what some of our research was looking at, to see, can we provide continuous vital sign monitoring as opposed to sort of the recommended 4 to 6 hours, which can be missed. There are often quite junior people taking those observations. Some of it can be bank staff, problems with escalation. So it's not only having, most hospitals now use the new system, but we know that it can also get missed and not followed out in the correct order. And it's trying to look at ways that we can help really triage patients so that the sicker ones perhaps get more attention than patients that are otherwise well.
Yeah, and I think, we've had a lot of talks at the meeting in the last 48 hours about the importance of not just that preoperative risk stratification period, but actually, one of the quotes from our speaker this morning was, the preoperative bit is the easy bit for us to sort. It's the postoperative bit which is still the big problem. So I think that all rings true exactly what you're saying. So what are your solutions? What are your answers? What are you looking at?
So we've been looking at a variety of different wearable sensor backgrounds that help provide more continuous monitoring, and they come in different types. One of the ones that we looked was a patch sensor that's placed on a patient, and we want also patients to be ambulating as much as we can, so we don't want anything restrictive. So it's a real balance between getting that balance properly and looking at which vital signs perhaps give us the most information. So we know that respiratory rate, for example, is often not measured accurately on the wards perhaps, and actually looking at, can digital monitoring of respiratory rate help us? And we also know that it's one of the early vital signs that shows deterioration. Similarly, heart rate, just 2 very easy ones to start with, which a lot of the wearable sensor platforms now monitor. Starting off with those and then looking to see how accurate are these sensors. So much of my research was putting sensors on our post-operative patients or our acutely unwell patients, and we did this at West Middlesex University Hospital. It was a really large study, but we had over 600 patients recruited because we didn't quite know the ones that would deteriorate. So you have to put sensors on lots of patients to try and find the cohort that may show signs of deterioration. Of those, it was about 17% or so.
I'd say about 15%.
Yeah, round about that amount. And we were looking at those that were going to stay in hospital and then taking a deep dive into the ones that had deteriorating and compared it to how quickly did the sensor detect it compared to nursing observations. And we had different parts of our trial where we used real-time alerting, or one where the early stages where we just monitored and didn't alert to just see how accurate was it feasible, compared it to nursing observations just to get a sense check, and then looked at times of interventions and so on.
So you talk about this sensor. What did this sensor look like? How do people wear it?
It was essentially a plaster on the chest,
Right,
with an electrode that went into the armpits that was sort of just a temperature probe.
minimal, really. Then.
Very minimal.
Yeah.
It was almost like not much bigger than a plaster.
Yeah, and I'm really intrigued by the fact you can get ethics to monitor this and not intervene if it shows. So how does that work? Where patients are potentially deteriorating, but you're not going to do anything.
So we were looking at although we were collecting prospective data, we were retrospectively looking at it. So because we didn't know which method was going to be more superior than the other, we also didn't know which method would be as accurate. So until we knew that data, and as soon as we found that actually in those cohorts, it was exciting data that we were looking at, seeing that we could pick up deterioration, and then we were looking at real-time alerting. Other parts of the work that we were looking at is trying to look at algorithms for alerting, because there's this real balance of leaving enough time window not to overburden clinical team members, but also to have you want to treat sicker patients as quickly as possible. So it's getting that balance right and making sure that the people that we were sending the clinical teams to with the alerts were unwell, and it wasn't a sort of a problem with their system or too much alerting. Getting that balance.
So you said this is 600 post-operative patients?
No, the initial trial, we did about 500 in the initial trial, and then the later work was in. So around about 100 in the alerting group.
Fine. And so what sort of patients were these that were in the alerting group?
Mixture of post-op and acutely unwell patients. So, sorry, the 500 also included acutely unwell medical patients as well.
Okay.
So we were trying to get those patients that we knew we'd stay in hospital for at least 24 hours.
And what did you find?
And we found that the system was accurate. It was able, and we've published this work now, so we know that there was good concordance between the sensor and the nursing observations, which was probably one of the first times it was used in a real world setting, as opposed to a lab checking it in healthy volunteers. And we also found that we identified some alarming and alerting systems that we were able to use in some of the next phases of our work, which I'll bring on to Jazz very soon. But yes, so we were looking at different ways of how those alerts fit in to help identify patients. As well as this, of course, there's a lot of work on usability, which was really important, and trying to get engagement not only with patients, but also our clinical teams. So the work was twofold. Half of it was reliability and alerting, and the other half was really the usability. What do patients think? What do staff think? How useful is it? We're trying not to overburden an already overburdened workforce, so trying to make sure that what we were giving staff was enhancing the experience, not adding to their workload.
And it's easy to sort of brush over that. We were looking at this and as it's very simple, reliability, but I mean, that's a huge problem. And a lot of the time we've done a lot of conversations on TopMedTalk over the years about wearable technology and about remote monitoring. And the question that I always get asked afterwards is, well, my Apple Watch gives me a heart rate and my Apple Watch didn't. But I take my Apple Watch, Garmin Watch off and it's still giving me a heart rate. It's not connected to me for a few minutes. That reliability issue is such an important thing to get right, isn't it?
That's a real challenge when you've got so much technology in the consumer space already. Yeah. Unfortunately, a lot of the consumer technology isn't tested to the standards that we have for medical devices. Part of that is because, let's be honest, you can sell the tech on a consumer level and not have to go to the cost and expense of getting a medical certification and going through all the international standards that relate to that. But there's no doubt, particularly if you look at the NHS 10-year plan that's just been published and what's happening across the globe, that there's a huge interest in how we provide healthcare differently. And we definitely have to do something in this space because realistically, we're not going to build more hospitals to provide the acute care. And from a surgical perspective, if the beds are all full of medical patients because they're not going anywhere, you still want to operate.
So Jazz, so let's pick up the story then. So how did you get involved with this work and what was the next stage?
So the technology has expanded leaps and bounds over such a short space of time post the pandemic. And building on the work which Meera has done, we started to look at this in a real world setting. So we used similar sensors monitoring the heart rate, pulse oximeter and the temperature. And we looked at this in a randomized control trial. So we're doing a prospective study where we can see what's not only the clinical outcomes of this in our patients, but also the operational impact and also the user experience, both from the patient's perspective as well as from the healthcare assistants.
Fantastic. So can we go into a bit more detail about that work? How did you perform it and which patient groups and what did you see?
Yeah, so we did a literature search and we found that there was a lot of retrospective studies and some before and after studies, but there was very little in terms of a randomized control trial in a prospective state. So we're running this at the West Middlesex Hospital. We're looking at 200 patients in a post-surgical unit, and we're monitoring them in a blinded and an unblinded cohort of patients where we can compare them comparatively.
So which patients are these specifically that you're looking at? So they're all post-surgical for
various, it's a general surgical ward. So there's mixed from urology, breast surgery, abdominal surgery, and then there's also orthopedic as well.
Right. And at what point do they start this monitoring process in that pathway and how long do they get the monitoring for?
So we typically pick the patients up after they've come out of theatre, when they're on the general ward, and we'll monitor them until discharge.
Wow, okay. And so what, I'm not going to hold you to numbers, but sort of median length of stays, are we talking 1 or 2 days or 5 or 6 days or?
On the ward in our hospital, the average length of stay is about 4 days.
Wow, that's a huge amount of data you're collecting then.
Yes, and although it's very early and we haven't analyzed any of this data yet, some of the user experience that we're picking up from our nursing staff has been growing over the last few months that we've had it on the ward with some positive experiences from patients. This has sort of fueled the nurses and their interest in the devices. So we see a lot of them engaging more with us now than they did in the beginning of the study.
Oh, that's interesting. There was resistance when you first brought it in, or is then that's more enthusiastic now, or?
Well, it's new technology and we're bringing it into an existing system.
Yeah.
So it initially looks like added work. There is difficulty when you do this as a research study because it involves recruiting patients, admitting them, logging various charts. So this is different from just running it in the ward.
Yeah.
So we've had some good patient experiences on the ward. Most recently, an elderly female who was in the ward that we recruited for our study, and we attached the device to them. We found that they were tachycardic, running at about 120. And she was on the alerting room, so it was escalated to the nursing team and to the doctors. They did an ECG and they found she was in sinus tachycardia, put her on fluids, monitored for a couple of hours, and all of this settled. Her relatives, which were much younger, were in the room as well. So this sort of drove the excitement of this technology in the ward amongst the nursing staff.
So in that example, then, it's a really nice example. If she hadn't been in the trial, hadn't been getting this monitor, what would the delay likely have been before that was picked up? Any ideas?
Actually, Meera can probably answer that question because we looked at that when we were doing her study.
Yeah.
That context, it was all retrospective, so we could go back and look.
Yeah, I'd say it was fairly variable, but we found some of the wearable tech was picking up deterioration over 12 hours before.
Wow.
So quite significant when you look at continuous monitoring and then you plug in where the next nursing observations were. And often that's where we picked up that respiratory rate in particular was flagging quite a bit earlier than the others. So there is some sort of physiological insult in the body happening, but it just hasn't quite registered later on. So many hours, but it was very much a case-by-case basis. But definitely when the alerts were going off and the alarms, the vital signs hadn't picked it up quite just yet.
Again, so just for people listening at home, it's probably worth just drilling into that in a little bit more detail. So for someone who's thinking, well, if the numbers on the monitor and the numbers different on the vital signs, how can that be the case? But I think what you're saying is that if you like, the sensitivity of the monitor is picking up more information than the vital signs are picking up on their own.
Yeah.
Can you maybe explain that in a bit more detail?
So the continuous monitor is obviously collecting data, packets of data, often fairly continuously or every couple of minutes, whereas if a nurse comes around to do observations, those are typically one snapshot in time. And often what we're looking at is trend analysis as well. So maybe a heart rate that's slightly up compared to the others might not alarm as much as perhaps a continuously trend of an elevated heart rate. So when we were looking at our sort of retrospective cohort, we could see that the sensor had gone off perhaps, and this is particularly pertinent overnight and over weekends where we know that monitoring sometimes is not as much as we'd like it. And so if a nighttime observation was done, in one of our longest examples, a nighttime observation was done, and then the next set of obs weren't until quite late in the morning, the deterioration had happened almost an hour after the nighttime obs and then weren't picked up until a lot later. So when we're looking at delays and we're looking at specific time intervals, this is where we could see yet the monitor was clearly picking up something that wasn't quite right.
And are these monitors picking up waveforms, or is it still kind of trend at individual time points that you're picking at?
The ones that we were looking at, we looked a little bit at both.
Yeah.
But more and more, I'd say the waveform analysis becoming even more, and Jazz could tell you a bit about that.
I think the newest technologies are picking up waveforms, but a lot of it is being analyzed at the back, and they're cleaning it out with various algorithms because remember, these are wearable devices. Our patients are interacting with physiotherapy. They're walking off the ward. There's a lot of artifacts that can be generated in some of these waveforms. So once they're cleaned up in the back, they present it in a way for healthcare physicians in a tabulated form and in visual form with graphs so that it's easier to detect these deteriorations and these trends.
And at the moment, is all that waveform clearing analysis happening manually, or is that inbuilt into the software? It's automated.
It's all automated and it's built into the software.
Fantastic. So, I mean, again, from outside looking in, from a listener at home listening to this, that might sound like a very simple question, but I mean, the amount of data that these things can generate in waveform analysis, when you're looking at, huge packets of data from one or two waveforms, and this thing is generating this for 4 days continuously, I mean, you can quite quickly overwhelm some processing systems or some analytical systems if you're not got a system to cope with that. And when you start feeding in different inputs from respiratory rates, heart rates, SATs traces, I guess there's the individual inputs, what each one of those is telling you, but then you can quickly start getting associations where 2 or 3 are changing at a period of time. Have you looked at any of that sort of work as well?
I think that's one of the biggest challenges with continuous vital signs monitoring at the moment, is we're having alarms being generated when each individual vital sign is outside a pre-specified threshold. And based on previous work that's been done, we have very lax thresholds. So for example, pulse oximeter has been shown that we don't set it at 90 or 92%, but for ambulating patients post-operatively, to reduce the amount of false alarms that are generated, we set it at 85%. The second thing that's done in the back end is there's a delay for these alarms to be notified to the healthcare team. It's typically between 30 and 90 seconds, depending on the vital sign. But work needs to be done in developing an early warning score, so track and trigger threshold that's we're used to both here in the NHS and all around the world, where we're combining these different vital signs, and we can then provide this to the healthcare team. That's where a lot of the data that you're mentioning in the back will generate and will be able to give meaningful outcomes to the patients.
One of the real challenges is just the sheer amount of data that's going to come through.
Yeah.
And realistically, no human clinician ever is going to be able to process it. So there does need to be really good models and methods of displaying that data in a way that's understandable. What we can't do, coming back to the human factors piece and how difficult it is to institute change in any system for anything, is put in a completely new system and expect that everyone is just going to be able to get with the program. So this issue of data, alert fatigue and how you manage it is a real issue. And one of the bits that Jazz is looking at is actually, well, how do we make this usable for clinicians? And there are a number of ways that you can just think about it. So the easiest way is you just alert on one parameter. So you're not going to try and start combining stuff. But we're in the artificial intelligence and advanced data analytics real world at the moment. So one of the things we're looking at is actually, can we utilize these sorts of advanced data analytical techniques to generate better insights for clinicians? And that's not just the data that the monitors are sending us, but that's also what we know about the patient already. So all the stuff that we keep in our electronic patient records and all the stuff that we're collecting from wearables, can we really start to leverage that and personalize care for each individual?
Exciting times. And I've got to ask, if I was a clinician on the ward where this was being used and I got the notification, how does that work? How do I get notified and what do I see when that notification comes through?
So different systems do it differently, but the ones which we have worked with more closely, we have a dashboard at the nursing station, similar to what you've probably seen in the ICU, where we have different patients on the screen. And they use visual parameters, so different colors like green or red, to signify patients that require sooner attention.
And what do the patients feel about all this?
There's mixed review from some of the patients that we've approached as part of the research study. I think there's a large proportion that are excited and they understand that this added layer of security that this devices bring. But there are some that are a bit more skeptical about having a device on them. About post-surgical patients may have drains or catheters, so they already have different devices on them, and they're worried about having patches or other wearable devices that they'll have to walk around with as part of their recovery.
That's interesting. But so they're worried specifically about the burden of wearing the device rather than...
Actually, I might come in and say, obviously, from Jazz's work's perspective, that's underway and we've just started. Yeah. But Meera did a very large interview study of over 500 patients as part of her research. And overwhelmingly, the feedback was positive. And we were talking earlier about consumer technology. So there's that pull element as well as the push element. So we are increasingly going to be challenged. Because if you sit at home with your Apple Watch, well, you can record your heart rate every minute of every day if you choose to. But yet when you come into hospital, you're stepping down from that.
Yes.
So I think a consumer level of technology is going to drive some of the changes that happen in healthcare. And because increasingly our patients are coming from that environment, their knowledge of wearables and technology in this space is actually much greater. Meera, do you want to just talk about that interview study that you did?
Yeah, absolutely. Thank you. I think just the acceptability, just as you were saying, Sadia, of people having wearables. Often when I do a talk, I start off by saying how many in the audience, whether it's clinicians or members of the public, have some kind of wearable device. And even within the last over the last decade of us doing the talk, it's just increased massively. So people are more used to or comfortable around wearable technology. We did 2 pieces. One was a questionnaire study and one was a deep dive with the interviews. The questionnaires found that, overwhelmingly members of the public were supportive, or patients were supportive in wearing the wearable technology, and they felt like it was an enhanced safety blanket or a monitoring system, even though, interestingly, in that 500, we weren't alerting in real time. So just the fact that they knew it was there and we were looking at the data afterwards still created that level of security, which was really interesting. From the deep dive, again, most of them found them to be acceptable. There were some concerns over, we want to make sure that patients are getting the right level of ambulating. So for surgical patients, there's lots of discussions around enhanced recovery programs, and most of our patients are on these programs just fairly immediately after surgery. So we want patients mobilizing as soon as possible. And this is where we found wearable technology can help this, providing that it's not too clunky. So right at the beginning of our journey, I'd say we've met lots of different types of wearable sensor companies, and we were trying to find the one that would be most acceptable for the majority of patients to wear. So, for example, I remember one that we met, Sadia, that was a sort of a very clunky watch-based system that was very heavy. And I just remember thinking, this is hard for me, let alone, an elderly member would really struggle wearing this. So I think making sure that it's acceptable is really important. That user feedback is so important. And again, with our nursing team, making sure that they're not overburdened with the alerts, having different triaging systems. Often we had nurse champions on the wards that were looking at the wearable and just doing checks on it daily, and that really helped. Often the most junior nurse would go and see the patient first, make sure they were okay. So if there were concerns or that alert wasn't acted on, then it would get to the nurse in charge, and so on and so forth. So there are various different ways that they can be applied, as Jas was saying.
And did concerns about data security or data breaches ever come into people's comments?
Yeah, very much so. And Sadia and myself did a lot of work on getting the governance and the data security clear, as well as having the technical bandwidth to do it. So we had to have a different server on our hospital system. We needed to make sure that everything was completely safe. So as soon as the sensor that we had worked on sort of Kuiper Bluetooth and radio frequency as well as Wi-Fi, but as soon as patients left a particular vicinity, the data cut off, so that we knew that that was merely a security element to that. So I think people are aware of others looking at their data, but I think overall, if it's being used in a clinical setting to enhance care, I think that's fairly approachable.
So I'm just going to follow up and say that Jas said earlier, and obviously we've been working in this field for a decade or more, but the technology has really, really evolved. And as people have become much more conscious about data privacy, cybersecurity, these things have come much more to the fore. So we've got an added challenge in the sense that we're under Heathrow's flight path. Any Wi-Fi or new system we put in place has to be checked against all of those frequencies. Oh. So the trust is well used to checking into stuff. When we first started, one of the things we did was all of our server systems were hosted on site. And that basically means that actually there's a security level because we can insulate them. And because it's a research project, the patient data is coded. So there is no patient identifiable data that's going into the infrastructure. As I say, because everyone's much more conscious of this and all trusts are much more conscious of this, that actually these systems have evolved to a level where you can use them in clinical practice and have a degree of confidence that the elements that you'd worry about in terms of privacy and cybersecurity have been dealt with.
So I've got to ask, just before we finish, why are we not already using these systems more commonly?
So I actually think Jas has answered that. So one of the huge challenges is just the absolute heterogeneity of the data that's out there and understanding how it applies to the environments that we're in. There's very little good prospective data. And the other challenge is there's very little good clinical effectiveness or cost effectiveness data. So the other big piece of work that Jazz has been doing is actually modelling and trying to understand that. I don't think that until we do that, we're ever going to be able to implement them into routine clinical practice.
Fantastic. Well, thank you very much for all the work you have done and are clearly going to continue to do. Let's finish on a slightly forward-looking thing. What should we be looking forward to in this space in the next, I don't know, say 3 or 4 years? Where's this going to go in the future?
I think this is a very exciting space. I think we'll have wearable devices that are very small and multimodal, so capturing a lot more vital signs than we routinely will think of, probably monitoring sleep and activity in our post-operative patients as well. And like Sadia said, with bringing in together data from our electronic patient record, we'll be able to tailor our treatment more towards each individual patient.
I think it's really exciting.
Yeah, watch the space. It's great to hear all the work you're doing and hear that journey through the care pathway. I think it's really, really important as well. So well done. Thank you very much.
Thank you for having us.
Yes. Thank you very much for joining us on TopMedTalk. As always, you can find this podcast and all our others on our website, on your podcaster of choice. We're on social media. If you do find us on social media, please do hit like, give us a thumbs up, and hit subscribe. It makes a real difference to us doing this work. And most importantly of all, a huge thank you to our sponsors, which this year are BD and GE, without whom we couldn't keep bringing TopMedTalk free and open access around the world. Thank you.
TopMedTalk. Next week on TopMedTalk, international perspectives on perioperative medicine. Andy Cumpstey with his guests Dave Selwyn, inaugural director of the Centre for Perioperative Care, Vanessa Beavis, past president of ANSCA, and Maxine Cannison, department chair of anesthesiology and professor of anesthesiology at UCLA, California.